Hello and Assalamu alaikum. Very good morning to all. I'm Dr. Sana Imtiaz, currently working as pediatric cardiologist in AFIC. I shall be discussing different vascular approaches and techniques used in ductal stenting in duct-dependent pulmonary circulation. Use of prostaglandin E1 immediately after birth and subsequent surgical creation of the modified BT shunt have remarkably improved the prognosis and survival of neonates with cyanotic congenital heart disease and duct-dependent pulmonary blood flow. Despite advancements in surgical techniques, bypass strategies, and post-operative management, significant morbidity and mortality after BT shunt still remains. So PDA stenting is an acceptable alternative to BT shunt in selected infants. And newer procedural techniques and operator experience have all contributed to procedural refinement associated with improved outcomes. So a meticulous pre-procedure planning is crucial to a smooth procedure and successful outcome. It includes echo evaluation for detailed arch anatomy, origin and insertion of PDA, morphology of PDA, and anatomy of branch pulmonary arteries. CT angiography helps in defining the anatomy accurately and a subsequent decision of the approach and choice of stent. These are few catheters we use during ductal stenting. Microcatheters are lifesaver and they help in crossing the constriction point and better parking of guide wires. These are 014 angioplasty wires we use in the procedure. So the approach and vascular access is planned mainly according to PDA origin. PDAs originating from descending aorta are accessible with relative ease from retrograde femoral or umbilical artery approach. But in neonates and infants, there is an increased risk of arterial thrombosis, trauma with femoral arterial approach. So to counter this, in case of a VST, an antegrade femoral umbilical venous approach has proven to be the best. Catheter position remains stable, and although there can be difficulty due to acute turns, but you are not worried about the arterial thrombosis in this vascular access. PDAs originating from head and neck vessels, they can be approached from femoral arterial or femoral venous approach, but the most difficult is the PDAs that are originating from undersurface of the arch. They are challenging to access, but percutaneous carotid and axillary access facilitates a direct and straight trajectory with easier maneuverability of wires and catheters. Previously, it was done with surgical cut down, but now the percutaneous access is considered to be safe. So we'll be continuing with the case-based discussion. Our first patient is 1 month old infant. He presented with pulmonary atresia, VSC, and duct-dependent pulmonary circulation. And since the child presented in a critical condition, we had to shift him to cath lab for emergency ductal stenting. We hadn't done detailed pre-procedure assessment with CT angio, so we were not sure of the vascular approach. Carotid artery, in this case, was accidentally pricked during an attempt to access internal jugular vein for central line. So we decided to go with carotid approach, and our catheter was, you can see, it was straight in PDA. We did an angiogram in lateral and aleocranial views. Here we found the complex anatomy with bilateral branch pulmonary artery origin stenosis. As the infant was crashing with saturations of 25% only, we were lucky that our wire was crossed and parked in right pulmonary artery, and we deployed the stent immediately. Here you can see stent in PDA, a little preferentially into right pulmonary artery. stent deployment in PDA, and it restored good pulmonary blood flow. It was preferentially directed towards RPA with jailing of LPA. How to deal with this problem, I'll show you in the next cases. Our patient number 2 was an 11.5 months old child. He presented to us in a critical condition with severe breathing difficulty and cyanosis and saturations of 35% in air. Diagnosis was congenitally corrected transposition of great arteries, pulmonary atresia, and duct-dependent pulmonary circulation. Ductal stenting was planned in emergency to improve the pulmonary flow, saturations, and growth of branch pulmonary arteries. This, owing to the complex anatomy, a CT angio was done, which showed a vertical tortuous PDA reconstituting confluent branch pulmonary arteries with severe narrowing at insertion point and origin stenosis of right pulmonary artery and left pulmonary artery. And right pulmonary artery was hypoplastic throughout its course. There was a right-sided aortic arch. Here you can see PDA originating from undersurface of arch and inserting an LP origin with the origin stenosis of left pulmonary artery. This is an axial section showing anatomy of branch pulmonary arteries. Right pulmonary artery is hypoplastic and origin stenosis of left pulmonary artery with post-stenotic dilatation. This is a short video clip showing anatomy of the arch, PDA, and branch pulmonary arteries. Short clip of axial view showing complex branch pulmonary artery anatomy. So after CT angio, we planned for axillary approach. But for axillary approach, first right femoral artery was accessed. Angiogram was done to delineate the right subclavian and right axillary artery. Unfortunately, I don't have that angiogram with me. But you can see that a 035 trauma wire was introduced into right axillary artery from femoral approach, and right axillary artery was then accessed under fluoroscopic guidance. And next, angiograms were done in areocranial and lateral projections, which showed a vertical tortuous PDA arising from undersurface of arch with severe stenosis at insertion point, as we have already seen in CT angio images. 014 BMW wire was used to cross PDA, which was then replaced with BHW wire using fine cross catheter. And 416 stent used to stent the duct throughout its length, just covering the distal end of the PDA, without preferentially entering into one of the branch pulmonary arteries through, and it was done through short sheath without guide catheter. We knew that there is LP origin stenosis, so it was addressed by ballooning of left pulmonary artery origin post-stent deployment with the 4 into 10 mm angioplasty balloon. Final result was good flow to right and left pulmonary arteries, and the future plan was to go for bidirectional Glenn. Saturations remarkably improved from 35% to 80%. Third patient is a 17 days old. He was diagnosed with pulmonary atresia, VST, and duct-dependent pulmonary circulation. And here we, echocardiography revealed that duct was arising from left subclavian artery. CT angio was done, and it showed a long duct arising from the base of the left subclavian artery with narrowing at insertion point at LP origin and LP origin stenosis, left pulmonary artery origin stenosis. This type of duct is the least common of ductus arteriosus, less than 5% of cases, and it gives a peculiar appearance of a BT shunt. These are static images. We plan to go for an antegrade femoral venous approach, and these angiograms were done in AP and aleocranial views. This is the the long duct arising from base of the left subclavian artery and supplying both pulmonary arteries. Angiograms showing PDA origin. Wire was crossed and parked in right pulmonary artery. And this time the ballooning of the narrowest point was done before the deployment of the stent. This ballooning led to the spasm of the PDA, so we immediately stented the PDA, and we used a single long stent measuring 4 into 24 mm to cover the whole length of the PDA. You can see stent deployment followed by good flow across the PDA and branch pulmonary arteries without jailing of any of the branch pulmonary arteries. Next patient is another patient with long duct arising next to subclavian artery. Patient had a right-sided aortic arch. We again went for an antegrade approach through femoral vein. This time the duct was stented with the two 4 into 16 mm coronary stents to cover the whole length of the PDA. These are the angiograms in AP and RA views showing a huge duct arising from arch next to subclavian artery origin with the constriction in its middle course. Here you can see the first stent deployment. After deployment of first stent, we observed a proximal uncovered part of PDA. So decided for second stent deployment. And after deployment of second stent, this was the final result with good flow to both branch pulmonary arteries, and both of the stents covered the whole length of the PDA. Next patient is a 12 days old patient with the complete atrioventricular septal defect, pulmonary atresia, and duct-dependent pulmonary circulation. Patient had a vertical PDA and a right-sided aortic arch, and we went for a femoral artery approach. Femoral artery approach is the most commonly used approach because of the ease of femoral arterial access. Ideal approach in this case was axillary artery, and we tried hard for axillary access. We went through femoral artery and placed a tromo wire in axillary artery, but we were unable to get the axillary arterial access, so we proceeded with the femoral arterial approach. This is angiogram in lateral view, showing arch, duct originating from undersurface of the arch and supplying both pulmonary arteries. We faced a great difficulty in crossing the PDA in this case and getting a stable wire parking. Moreover, as the access route was not straight and direct, so stent was advanced without guide catheter. Final deployment of the stent resulted in jailing of the left pulmonary artery, which is evident in this angiogram with the decreased flow towards left pulmonary artery. This problem was then addressed by crossing the struts of the stent by another wire and parking this wire in left pulmonary artery. Struts were then sequentially ballooned with 1, 2, and 3 mm angioplasty balloons. This is the final result. About 1.5 hours. Total, but the total duration including anesthesia, and it was more than 2 hours. But we were lucky that child survived, and we discharged the child in a stable condition. Actually, this happened because of the initial deployment without the guide catheter. We didn't had the option of doing an angiogram to find that whether our stent is in the right position or not. So I shall be winding up my presentation by saying that ductal stenting requires a high degree of technical skill with, of course, an expert pediatric cardiac anesthesia team and a surgical backup and ECMO support. Techniques of ductal stenting have evolved rapidly over the past few years, leading to higher success rates, and attention to anatomic and technical details optimizes the success. Thank you.